very much, Mattia. Thank you. First of all, I would like to thank the Society for the privilege of giving my thoughts to that topic. And I thank you, Mattia, for doing my job, actually, because you were talking about sutureless. So here are my potential conflicts of interest. The simple answer is yes, they do. Thanks very much. Thank you for listening. Goodbye. I think it's not that simple. And I just would like to share a few of my thoughts to that topic with you. So first of all, why did the sutureless prostheses come into place? They were developed to simplify the surgical technique, to reduce the implantation time, and thereby making mini-invasive access surgery possible. But on the other hand, compared to TAVI, they are still a curative treatment. That means we remove the old valve, and we are also open for concomitant procedures, and that is one of the major drawbacks of TAVI. Professor Moore stated that already, and those are the numbers that were available last year. They're always a little bit behind to real world, and I think they should be coming out sometime this spring for 2013. So what it shows clearly is the green bars are the surgical valves, so we are still in a kind of a steady state at that time, which was up to 2012. The TAVI market is growing tremendously. So 46% of sole aortic valve interventions in Germany in 2012 were done by transcatheter techniques. So the question, of course, is where are we going? And I absolutely agree. So there will be at some stage probably a saturation of valve interventions. The TAVI market is going to grab off of the surgical market. But obviously the question is, will they at some stage eventually be able to really take over completely? On the other hand, if you look onto German surgical data, the Germans are the perfect mini-invasive mitral valve surgeons. 46% or 45% of mitral valves are done through a mini-invasive access, but only 18% of the aortic valves. And especially in my hands, I find the mini-invasive access for aortic valves much less complicated and complex as compared to the mitral access. So why don't people just adopt the new technique? It's something new, time-consuming learning curve, all the things that we've gone through during the last couple of talks. New devices, new cannulas, is there a bailout? Because we are interested, of course, in patient safety. And then, of course, we have to pass the technique on to our younger colleagues. So teaching is an issue. And we know all that about the discussion, is mini-invasive access justified? Late 90s, everyone said, okay, it's time-consuming, it takes longer, so why the heck should we pursue? And then, of course, some of those publications have already been mentioned. It's always the same. That means that it is worthwhile, it's non-inferior, it's more time-consuming, it cranks up cross-clamp time. But if we can handle it, if we take it into the hands of experienced surgeons, usually we don't take much longer, and we can do it, it's justifiable. Why? What was the driver for us in Nuremberg to adopt that technique? Well, first of all, we have a couple of other institutions sitting right next to us, so of course it was attract the referring cardiologists. We wanted to attract new patients. We wanted to challenge TAVI, because I'm still convinced that at the time being, surgery is the standard and best option for the patient. We read about this, that it's non-inferior to full sternotomy, but for us and the technique that we are doing, it's not a complete new technique. That means that we can't see the heart anymore. We don't need it because we have the TOE, but we do integrate central cannulation. We cannulate the aorta, we cannulate the right atrium, and so for us there was no real big difference. It was a step-by-step development of the technique, and we had a bailout. If you have a problem, then just extend the skin incision and do a full sternotomy, and you are there. That's what you're used to. That's what some of us have been doing for the last 30 years. And then, of course, there was another driver for us, which was then sutureless valves. And that has been very nicely shown that independent of the type of sutureless valves that you were using, we were still always reducing cross-clamp times, not only in isolated aortic valve surgery, also in concomitant surgery, compared to very well-known databases or, for example, the partner trial. So does time matter? I mean, that's always of great debate. And this is also publications that we've just been shown. And basically, the message is usually the same. Yes, it does matter. And some even pin it down, as Ranucci, to a 1.4 increase of morbidity per minute of cross-clamp time. But basically, they're all saying the same. Yes, time matters. The faster you are, the better it is for the patient. So we did a very simple study. We looked at our early experience with mainly with the Perceval. That's our preferred sutureless substitute. And we just looked very simple at. We just looked very simple at 100 patients. 50 were done with a partial stenotomy with a sutureless valve, compared to 50 traditionally sutured AVRs also with a partial stenotomy. And if you look at the patient cohorts, they are not comparable at all. Our sutureless patients were older, they were sicker, they had more concomitant disease. And that's a little bit different to what my predecessors just said, or my previous speakers. That for us, from the very beginning on, sutureless was for us preserved or reserved for high-risk patients, where we thought that shortening cross-clamp time would make a difference. And that's what we found out in those patients. Of course, we could shorten cross-clamp times. That's what has been showed by my previous speakers also, and by all the publications that you are, I'm sure, aware of. We also found faster recovery, shorter ventilation times, shorter ICU stay, less blood transfusion, which we account for shorter pump times, no difference in early mortality and pacemaker implantation, and we could even reduce costs, although we didn't consider the device costs at that time. So the next step then was for us to define the patients that could really profit most from that technique. And if you look here, those are the patients that are sensible to cross-clamp time, multiple risk factors, diabetics, low EF. That's what also Ranucci said in his paper. Then it's obviously some complex cases where you want to avoid manipulation of the root, which is very often redos, small annuli, calcified aortic roots. And then it's the mini-invasive patients. So who would profit there? Older patients, obese patients, patients who need a less traumatic procedure. So basically, when you then look around, this makes up almost 100% of our patients that come to us for an aortic valve surgery. So my conclusions are, for the time being, surgical AVR is still the gold standard for AV stenosis. And the sutureless valves can really help in reducing cross-clamp time and pump time. We've seen that, and we've shown that, and other groups have shown that also, which can then be crucial to minimize patient morbidity and mortality. And then, of course, for people who are still reluctant in starting a mini-invasive program, it can help them building up that program, and thereby improve outcomes in surgical patients. And to me, still, they are the two key elements to fight TAVIs. Thank you very much for your attention.